So today we are halfway through pediatrics this quarter. Can you imagine it? It's amazing. This week we're going over hematology, immunology, and children with cancer. We're also, quiz 4 is there for you. And the two case studies, congenital heart defect and cystic fibrosis will be due. And this is the week of the NCLEX. So most of you have turned them in already. That's fine. Because remember, I said I opened up the NCLEXs because I know that with 3 courses, you have a lot of stuff due. So there was some things that I let you work ahead on, and some of you have. Remember when we get down to next week, it does start mentioning the pediatric clinical assignment. Now, those of you who've turned in early, I've had a chance to review them. I've had a chance to tell you what you need to change in order to get a better grade. I'm not just going to let you fail without giving you opportunities to change it. So just be careful with plagiarism because it goes through a plagiar checker before it gets to me, okay? It's only a 250-word paper on a diagnosis that you choose. And remember, a child's diagnosis. Then you're going to do a pediatric assessment. Just to put not applicable or normal, that's not what I want to see on any body systems. Explain, what does a heart sound like? What do lungs sound like? Talking about, cerebral, awake and alert, and what else goes along with that. And then the PowerPoints just on teaching. So what are you going to teach a patient? Maybe with asthma, maybe a patient who's a child with chronic urinary tract infections or ear infections. What are you going to teach? So the PowerPoint could be 5 slides. Don't go crazy. But remember, every section goes through a plagiar checker to make sure that you're using your words. You can go to many sources and find the answers. Just change the words to you, okay? Just switch the sentence up. There are some students who are having trouble with that. And if you do, just let me know, okay?
Professor Bogart?
Yes.
My Canvas has 2 quizzes for this week listed. I don't know if it matters which one I take, but it just says quiz 4 twice.
I have the same thing in mind too.
Do you really? Quiz 4. Let me see. Hold on, I'm going right to the assignments and checking that out right away for you. I have it listed once. I don't see anything different than that. Let me refresh and make sure that's exactly what I see. Quiz 4, I have it. Again, I have it listed once. It shouldn't matter which one you take then, because there's one quiz, okay? Maybe you do it once and do it twice. I'm not sure, but I don't see that on my side at all. I'll review it a little bit closer, when I have a little time after class. So I'll make sure, but thank you for letting me see that and know that. Appreciate it. So let's start with our PowerPoint. Again, hematology, immunology. So it is chapters 43 and 44. So when we talk about hematology, immunology, we're talking about something in the blood that either helps, boost the immune system, or it's something, to carry red blood cells or white blood cells to, help with infections that can show you that there's infection. So when we're talking this subject, how do we rate? How do we look at it? How do we know what's going on? We're just going to do a simple complete blood count, a CBC. Let's look at the hemoglobin, hematocrit, the white count, the platelets. Let's see, you know, what's in that blood, and we can make determinations what's happening. Many times what happens and what makes the physician draw these bloods is these children are all of a sudden, the parents are telling you they're just not as active, they're not as tired, they look pale. And then when we see that lack of energy, we can probably think it might be anemia, because what does the red blood cells do? It carries around oxygen. No oxygen, there's no energy to be able to do those things that kids do, run around, jump and play. We know at that ages, you know, in toddlers, we go through that, you know, physiologic anorexia because they're not eating as well. And then of course, are we getting all the iron we need from the food? When we see children bleeding, whether from the gums or rectally or sores that are just bleeding too long, that's going to give us some clues too. And then children who are chronically ill, what's going on? Let's look at that CBC. So the red blood cells, the most common of all disorders is anemia, and there's many types of anemias, and we'll go into what they are. But when we know there is no red blood cells, we don't have as much oxygen, right? So we are going to have that decreased oxygen carry capacity. So now we don't have that energy the body needs, so it tires easily. And that's always going to be your complaint with the parents. We know that red blood cells do die off. We know that there are some sort of red blood cells that are all different shapes and sizes, and we're going to go into that. So we say that anemia in children is a hemoglobin less than 10 or 11. And actually, when we see hemoglobin 10, 11, that's when we say, okay, the child doesn't need any more iron in the vitamins. So here's the type of anemias, and it could be due to decreased red blood cell production. And what do we see with anemia? Well, of course, that pale look. You look at the gums, you look at the ears, we're going to see it paler than we normally see. The heart is trying to work, trying to get the blood around, so it's tachycardic. We're going to see short breath, fatigues easily. And then because of the cells bouncing off of each other, because there's not a lot of cells, we'll hear swooshing and we're going to hear a murmur in the heart. So that's usually a telltale sign. So we have nutritional type, which is iron deficiency, folate, B12, and then if there's any sort of chronic blood loss there, we'll see that. If it's a bone marrow failure, we might see aplastic anemia. And aplastic anemia is all sorts of blood cells deficiency. So A, absent, okay? Always think A, absent. So we will say this is the one that covers all different areas in the blood. There is an increased blood loss, and this is usually due to nosebleeds, hemophilia, something called ITP, and it's idiopathic thrombocytopenia purpura. What a name, huh? What a mouthful. But when you see purpura P, think platelets, decreased platelets. Therefore, you're going to see bleeding. And then there's an overwhelming thing called DIC, disseminated intravascular coagulopathy, which means all of the blood components are not working together. Usually it's due to overwhelming sepsis in a child, and this child is really sick. We do have times where we do have red blood cells, but they're destroyed quicker, they die quicker. And the one that we know the most and have heard about before is sickle cell anemia. We also see it in thalassemia. And then sometimes it could be due to some immune in the body, or it could be due to, what about that chemotherapy that we get for, let's say, the leukemia? So when we have low amount of cells in the blood, you can see they're not all bunched together. So now you're going to see why they swoosh, because they're just bouncing off of each other. And again, you're going to hear that murmur. That's one of the things that a physician will do first: see the color, look at the color in them, listen to the heart rate, and then say, oh, I hear that swishing. And that's going to be a telltale sign. We know that you might see anemia because there's less red blood cells, less oxygen. And remember, the body needs this to be able to grow. So this child, due to lack of oxygen, which is a normal part of their body, you might see them smaller because of anemia. So again, how do we go ahead and diagnose it? Well, it's the history first. It's going to be that bleeding, or if it's going to be, you know, being tired, and we're going to be doing a CBC, simple CBC. If it is a low hemoglobin hematocrit, we will treat it, but we need to know why. Why did it happen? Not just treat by giving blood transfusions, but why? Why did we need to give that blood transfusion? We tend to treat the symptom, but not the cause, and we don't want to do that. If it is nutritional problems, iron deficient anemia, we're going to add iron to the diet or give iron medications, or maybe we're going to be giving those iron IM injections to these children. And this is what we'll do to help treat it. When a child comes in with really low hemoglobin hematocrit and, you know, they're really tired, we might decide to give some volume because the heart doesn't have volume. Be careful though. Once you take a low hemoglobin hematocrit and dilute it more, the number even becomes lower. So this is why bed rest, exert no energy, and also put them on some oxygen, which could help a little bit. But remember, there's only a certain amount of cells that can carry oxygen. So oxygen therapy, hopefully it works. I think it's more of the bed rest. So as we assess it, we need to look at the age of the child, and we look at the racial or ethnic background. We know sickle cell anemia is African Americans and thalassemia is Mediterranean descent. So this would give you some clues. Doing a really careful history. What's going on? What did you see first? How long has this been going on? And we always rule out that losing blood in the GI system. So we'll do a stool for occult blood. As we go to children and we want them to get ready for what's going to happen with anemia, always prepare them. You know, one of the questions was, you know, when you have a child and you want to do something to them, first we approach them and we're not touching first. Remember, we're going to sit next to them. We're going to talk to them, tell them about their cute dimples or the shirt they're wearing or sneakers. Then we're going to show them the equipment and let them touch it and feel it. It's in that introduction. You just don't shove the equipment in their face first, because now they're scared. Now you've walked in, no approach, and they're going to be more frightened. So it is number one, getting them used to who you are first. So get them prepared. Remember, if they're anemic and then they're screaming and yelling to get blood drawn, they're burning up energy, which again is not a good thing because they're already anemic. So we know that oxygen is not going where it needs to go. And with anemia, we're trying to prevent those complications. We need to correct it, or the heart's going to keep beating and the heart's going to go into failure. So iron deficient anemia is because of dietary iron. We know that the infants, if they're not on breast milk, are going to be receiving iron fortified formulas. And then at 6 months, when we introduce cereals, it'll be iron fortified cereals. Now, adolescents are at risk for anemia because we know that that body image is so important, and they're not eating as well as they should, and they're eating on the run, and they're growing really quick in the beginning of their adolescence. You know, that can lead to also anemia in those adolescents. Many times iron deficient anemia is what they say milk baby. So giving them regular milk with no iron in it, even at a year old, sometimes that can force them into iron deficient anemia. So how do we treat it again? We're going to increase the amount of iron, whether dietary or vitamins, or even, you know, dextram injections, you know, whatever we have to do. So diet and iron supplementation, and explaining to the parents which foods are high in iron. So sickle cell anemia is those sickle-shaped cells that most of them are African American, and there is traits. And then the traits will show you how much percentage a child could be prone to having the disease. So if both parents have a trait, each child has a 25% chance of having the disease. And then they're actually in malaria is common. They have a lot of sickle cell traits, and they actually do better with the malaria. It's a crazy thing, but it's a little interesting information. So sickle cell, what happens? What happens is we have a bifurcation of a vein, and right at that bifurcation, a sickle cell comes and covers it, and the cells behind it tend to load up. So blood's not getting down, and now this area here is swelling. So we're going to see stretching, pain. It's going to cause redness. It's going to cause swelling in that area, and these cells are going to be stretching and squishing together and bursting and dying. So how do we take care of this? So blood's not going down to where it needs to be. So oxygen isn't being carried to what extremity. Maybe it's the hands, the feet, whatever. It could cause local hypoxia, cell death, and it could cause problems because of that lack of oxygen. So we need to stretch that bifurcation, that vein, get it open, let blood flow down there. So the first thing we are going to do is start an IV and give fluids, okay? Yes, there is pain, but that's the second thing you're going to do. You are number one going to stretch those veins open, and hopefully now they're big enough, they're dilated enough that now blood can flow where it needs to go, okay? So that's usually the number one things. Now, why does sickle cell crisis occur? It's anything that you need more oxygen for. If you are, very active in sports and you are, moving a lot, you need that oxygen to be able to do those things. And that can cause a sickle cell crisis. Trauma, bruising, infection or fever, probably number one. These children and parents are said, any fever over 100.5, they need to call their physician because they need to treat it immediately. Because with fever does what? It causes dehydration because it, takes the fluid away from the body. So what does decreased fluid in the veins happen? Sickle crises. So that's a big deal. Emotional, physical stress, big time cause of a sickle cell crisis. And then anything that causes dehydration. I've mentioned fever. Let's say they're out running around playing sports, they have no hydration, that can cause it too. So diagnosis and managing of it. Well, first of all, we're going to try to prevent those sickling attacks. There are a cocktail of medicines that these children get. They're going to get some folic acid. They're going to be getting one penicillin pill a day. And that's just, prophylactically to try to help. These children are taught to keep hydrated. Please keep hydrated. And then make sure that they rest. And then if they're having a crisis of emotional stress, physical stress, to talk to somebody about it, to try to help get it out of there. We will, when we are having a sickle cell crisis, number one, hydration first, okay? Then pain medications, and then heat does dilate the veins too. So those three things would be the first, but remember, priority treatment will be your IV. As I said, most of these times, these children come into the emergency room, these children are having a fever, and that's what causes sickle cell. So making sure the electrolytes are where they need to be and that they are getting antibiotics. Many times in a sickle crisis, because those cells are being destroyed, I've seen hemoglobin and hematocrits 15 and 15. So these children are getting blood transfusions in the emergency room before they even go upstairs to the floor, because we want to get that oxygen back to that child so that they can breathe easier to help the heart out. The prognosis is there's no cure, but maybe a bone marrow transplant will help. They're not sure, but I've seen them give those transplants for some of these children. Always, support whatever their sickling episodes are with hydration, pain medicines, antibiotics, electrolytes, whatever they need, blood. And also be aware these children will have, they're immunosuppressed. So they will have frequent infections. So to have these children get into the emergency room as soon as they can. And the bacterial infection is the leading cause of death. So that's why 100.5 fever, they need to get to their physician or go to the emergency room so they can get treated with those antibiotics. Most sickle cell children become adults and they live into their 50s, and some more if they're taking care of themselves well. The clue is to seek early intervention, give that penicillin, like I said, and know that sickle cell isn't only in a hand, a knee, a foot, it could be in the brain. So if we are seeing, some weakness on one side or pupils unequal, this could be a sickle cell crisis. And we don't think about that as sickle cell crises, that it could be in the brain. Also, remember, it could cause, looks like a pulmonary embolus, that pain and, can't breathe that well. And those are the most serious of all the sickle crises. They have the chest, but in the lungs and in the brain is the most. These children we need to treat like normal children, but they need to be told how to keep themselves hydrated, how to wash their hands, prevent infections. Very, very important. You can see this. I found this picture. I was going through on Saturday looking for a picture that really shows sickle cell and a bifurcation and what happens. And I think it really shows that you can see the vein gets a little smaller and you see it sort of bunch up at those bifurcations. And that's where we see sickle crises. So rest, minimize energy loss, hydrate, electrolyte, analgesia, blood, infections, and that prophylactic antibiotic for 2 months up to 5 years old is what they give children. They do monitor the retic count to see how is the bone marrow working. Is it producing cells, okay? And again, blood transfusions can really help with hypoxemia and ischemia. Thalassemia is another sort of red blood cell disorder. It is a shortened life. And if you look at them, these are rectangles. So we have sickles and now we have rectangles. And basically what happens is these things burst and they burst and they burst. So shortened life, bursting RBCs, you're going to see iron in the blood. So these children have too much iron in their blood. So they need some sort of chelation therapy. As I said, it is descendants of people near the Mediterranean Sea. Now, there's 4 different sorts of thalassemia. You don't need to know what's the difference. You just need to know that Cooley's anemia is the most severe of all of the thalassemias. And this is a child who will need to have transfusions regularly to live. That's how quickly their cells are bursting. Usually we see it, not at birth. We see it a little bit later on. What we will see is hemoglobin and hematocrit levels are going really down because they're bursting. And we'll start to see those red blood cells change about 6 weeks of age. And if we are not getting oxygen to an infant, it's like not having any nutrition. No nutrition, you are going to see a child who's not growing at the proper rate because there is no nutrition, which is their oxygen. So our goal is to give blood transfusions as needed to keep hemoglobins where they need to be. And then, of course, the big thing is those bursting cells, the hemosiderosis, which is the cells are just bursting and the insides are going through the blood system, which is full of iron. So we need to get rid of the iron. So we will be giving an iron chelating drug called Desferil, and it helps combine with the iron and get rid of it. Also, you might see these children on something called an apheresis. It's sort of like a kidney machine, but this one, dialysis, but this one can remove, cells just like that. All right. Prognosis. This is a really hard disease to live with. They can live into adulthood, but remember, these patients, these children who become adults, they need to get regular blood transfusions. And really, it depends on what's your blood type. Do you have blood available to give you too, right? And if you're always living with anemia, think about that heart. It's going to fail, and it's going to get big and floppy because it's trying so hard, and it usually goes into that heart disease. Many of these children, they'll take out the spleen to stop producing these irregular cells that are bursting and putting out all of this iron. And they say maybe, again, a bone marrow transplant is maybe the cure here. So, as I said, the care management, what do you expect? This child needs good compliance with transfusions and chelation therapy, getting rid of that iron. And these children are going to be in and out, constantly getting blood tests. They're constantly going to be getting blood and even taking their medicines. And some of them is hooked up to a machine. And depending on the severity of thalassemia, depends how frequently it needs. Sometimes it's once a week, twice a week, once every 2 weeks. They're all different. So that's something that you can, say how often. This is a family disease because the whole family is involved with getting this child into the physician, getting the blood that they do need. And again, multiple blood transfusions has its risks. Aplastic anemia. Now, this is one that we see a profound depression of RBCs, but normal white blood cells and platelets, okay? It is also, we do have the panxedemia, which is the anemia, leukopenia, so white cells, and thrombocytopenia, which is platelets. So there's two types. One is more severe than the other. The hypoplastic is just your red blood cells. So you can be born with it or you can acquire it. What is the treatment? Very similar to what we do for the chemotherapy and the course of treatment that we do for leukemia. So immunosuppressive therapy, telling the body, stop, destroying my red blood cells, and then a bone marrow transplant is what they need to correct what's been going on with their body and this profound killing of their red blood cells, white blood cells, and platelets. So now we're going to look at defects in hemostasis and talking about clotting. And if we think of this, we're going to talk hemophilia. Hemophilia, the blood is thin, which means there are certain things in the blood that you need in order to clot blood when you have a cut. In hemophilia, there are 3 different types, okay? It comes from mom, X-linked recessive gene that can cause it. Once we determine that the child's bleeding, it could be not at birth, we didn't know, or didn't know to look. We can see the child bleeding in the gums. When they're cut, they're bleeding a lot, they're bruising. All of these things will bring them to the physician when there's no reason for it. Then we need to figure out which factor is it. And as I said, there's 3 types. There is hemophilia A, which is the normal, factor 8, which means if we have a child with hemophilia deficient of factor 8, this child needs to be given, and it's a medicine that we need to infuse that's called factor 8 that we give to the child. Hemophilia B is also called Christmas disease, but it's factor 9. Their 8 is okay, but their factor 9, another component of clotting, is not good. So we need to give that one. And then there's something called von Willebrand's disease. I love the name of that thing. But it is the von Willebrand factor, which is the gentleman who found it, that is a factor named for him, and factor 8. So it's a double one. These children, you need to be very careful with bleeding. So usually, as I said, we're going to see a history of bleeding, big bruising, swelling that's going on, the hemarthrosis, The biggest problem with hemophilia is when a kid falls down on a knee and swells into a knee, and it's in the joint that causes joint destruction. And if we're not on top of it and we don't take care of that bleeding in the joints quickly, it's going to become destroyed, those joint areas, and these children will end up in a wheelchair. So it is imperative that we treat it really quickly once we see those things. So what we see with hemophilia is a low factor of whatever it is, 5 or 8. You will see a prolonged PTT, okay? But what's normal? The platelet count and these other 2 levels, parathyroid and fibrinogen. So platelet counts are normal here. It is something that we say, well, I thought it was all of them. No, it's just the bleeding factors, and those bleedings show that PTT, like heparin, it'll show it elevated. So how do we take care of this? We're going to replace it, and they do it at home. And I've seen these children get these things in the emergency room. I had a father come in with a 9-year-old who literally, the kid fell on his knees, it was bruised, and he didn't know if he should be giving the factor. I guess he had just had it, that week, and he couldn't get a hold of his hematologist. So he came in and they said, go ahead, give it. So he had brought his factor in. The boy chose which vein. The dad was going to stick a little butterfly in. He mixed it up and gave it, and it was probably better than most nurses could do. It was amazing. And the boy was happy because daddy did it. I didn't have to do it. The father knew how. And the father felt pretty cool that I said, wow, that was pretty awesome. You did really good. He's like, yeah, because I have to take care of my son. And I just thought it was pretty neat. Sometimes, though, we can just give nasal spray, and these are very mild sort of hemophilia. And sometimes aminocaproic acid can help, with the clots. So prognosis, as I said, you have pretty normal life, except for the bleeding. As long as we take care of those joints, we need to take care of those joints well. How would you do that? Hit his knee at home and it's swelling. Remember rice? We're going to raise it, ice it, we're going to wrap it up, and we're going to elevate it. Just like you would do for a sprain, same thing we're going to be doing for a hemophilia who has, an area that we can raise and ice to protect that joint. And we're going to be giving that child at home a home treatment for it. So what do? We try to prevent bleeding at all costs. If you were a child in the hospital, we're not going to be given any IM injections. What's that going to cause? It's going to cause bleeding, right? We're going to do bleeding precautions. We're going to be watching soft toothbrushes on these children, no IM injections, and we're going to be monitoring his PTT and blood counts as they're ordered. Again, we're going to control the bleeding with rice. And I've got one here that actually goes price, and I think it was pretty good. The first thing is to protect it. Don't let rice happen. I think that's good. And again, it is genetic, so the family might need some counseling on that. Immune idiopathic thrombocytopenia. This is called ITP. Remember, P, purpura, has to do with P platelets. So low platelet count. And these children could be, 6, 7 years old, and they never had a problem with it. What usually happens with this condition, and it could be transient or it could be lifelong, usually after they've had an upper respiratory infection, a couple of months later, all of a sudden they're going to be seeing bruising. And if you see it's petechiae, it's like little purple little marks, legs, arms, trunk, somewhere, sometimes around the face. And what it does, it alerts the parents, like, kid has this rash. I've given him Benadryl, put steroid cream, nothing's helping. Of course, it has to do with a blood problem. And that brings them into the emergency room or the physician. And what they'll do is they'll do a CBC. They'll look at the platelet count, and they'll find the platelet count is low. So what do? We give IVIG, which is your immunoglobulins intravenously, There's an anti-D antibody that we also give. And then sometimes we give corticosteroids. And usually we will turn this around. So again, watch the child for bleeding, avoid any venipunctures, monitor those blood counts, give corticosteroids as you need to, and make sure that the child and the parent knows to protect from injury. DIC is basically a disorder that has to do with the whole blood system isn't working and your blood becomes really into fibrogen and destruction platelets and you're bleeding. It's a very difficult disease to treat. Very ill child. You're hypoxic, acidotic, you're in shock. We will be following blood counts closely on this child, PTT, thrombin, D-dimers. We'll be given heparin on these children and continue things. Very complicated thing. I'm introducing it because it is a bleeding problem that children do get. We need to first see that this is starting to happen, which you'll start seeing bleeding from somewhere, maybe nosebleeds, maybe rashing going on. If it is due to a septic problem, treat the sepsis first. And we will be given platelets and FFP because this child is bleeding, and it could be internally too. Newborns, we'll be giving them an exchange transfusion. We pull blood out and put it in at the same time. We use this for hyperbilirubinemia too. We exchange blood to help get that bilirubin down. And as I said, we're going to be given heparin to these children. So sick child. Nosebleeds. Believe it or not, nosebleeds is what usually brings a child in with suspected bleeding problems. They have had repeated. So they've gone to their doctor, they had a nosebleed, and they are, had it a week ago and they don't know why. They were just sitting there and they started to bleed and it was a lot. So the first thing they do is they just paint it with some Vaseline. Maybe it's, the fall and it's dry weather and dry houses, whatever. Let's paint it. And it still continues. So this child, after that, they'll go in and they will do some blood on them, start with a CBC and work from there, and they could figure out if it's a bleeding coagulopathy. What do we do for this child who's having a nosebleed? Well, number one, they're bleeding. They think their insides are coming out and they're dying. So keep them calm as we can. Have them squeeze their nose and lean them forward because we don't want them swallowing it. And if it still continues, they need to go and seek assistance. Now, an immune issue that occurs is HIV and AIDS. And a lot of times we're talking, let's say just the infants. We're talking about maternal, mother to child. Now, if it's a mother to child risk, hopefully the mother has started some heart therapy, which is a highly active antiretroviral therapy, and it can help in the beginning to improve that newborn's immune function. Our goal for this infant is to improve their immune function. They can seroconvert and not be HIV if we can boost their immune system. So it's not always that if the mother has HIV, the child will too. I've actually seen twins, one had HIV and one did not. So it all depends on the child. Also depends if they've given these therapies, and then at birth, immediately we're giving more. So again, the things that happen with HIV as we're watching these children, especially if they're the young ones, we're worried about their respiratory that occurs is pneumocystic pneumonia. PCP pneumonia. And this is usually those young children, 3 to 6 months old, and they're really having difficulty breathing. We know that's pneumocystic pneumonia, and we really need to treat that. We need to get their respiratory system functioning as best as we can. We know there's other things that can happen with yeast, etc., but the biggest one that we're concerned is the PCP pneumonia. So education, teaching our adolescents, to, of course, we can say abstinence, but, adolescents will be adolescents. So at least teach them how safe sex and where to send them to if they need any help with that. Also, HIV, it can be painful. And remember, many people look down on children with HIV AIDS, and just to support those families is important and keep that their diagnosis is confidential. So management of hematological immune disorders, we know number one is blood transfusions. Remember, with blood transfusions, you always are aware of transfusion reactions. If we suspect any reaction, number one, what we do, turn off the blood, get it off, and then we'll send that bag down. And always use the guidelines set up by your program. When I was giving blood, you would take vital signs, hang the blood, 2 nurses checking, blah, blah, blah. Hang it up, 15 minutes later, take another set of vital signs, and then every hour for the 4 hours. And if we saw anything, immediately turn it off, send it, notify the doctor. And we do put these things on a pump to make sure that we're giving them at a proper rate. I mentioned apheresis when we talked about chelation therapy and iron, and it does just remove certain things out of the blood, and it can actually just take platelets out so that we can give it to that child, maybe with ITP, and platelets are low and it's not responding to other treatments. So when both parents have sickle cell trait, what is the chance that each of their children will have sickle cell anemia?
25%.
Yes, ma'am. Good job. Okay, neoplastic disorders. Most neoplastic or cancer disorders in children are usually, almost half of them are blood forming organs, which is your leukemias and your lymphomas. Leukemias, there's 2 types. There's ALL, acute lymphocytic leukemia, and AML. And this is your acute myelocytic leukemia. So ALL, AML. Now, ALL is actually the better form. So if you ever hear of the 2 types, they say ALL, this is better outcomes than the AML. It is more frequent than in boys, and look at the peak onset, 2 to 5 years old. Can you imagine getting a child who's 2 years old? Let's say you're in the doctor's office or in the emergency room and they do a blood and they find out that this child has leukemia. Now you have family that you have to support. It's happened to me and it's very, very difficult. Survivability is great as long as it's treated. What is leukemia? And this is the definition. Unrestricted proliferation of immature white blood cells in the blood forming tissues, which means there's white blood cells, but they're not doing anything. They're just immature. They're not working at all. And what do white blood cells do? They fight infection. So these children cannot fight any infection at all. They're severely immunosuppressed. And the liver and the spleen are the most affected organs in this. And, all of the things that go on with whether it's a tumor, leukemia is going to follow the same sort of symptoms with it. So based on history, so what history would you say? Well, I had a next door neighbor, went to the emergency room. She was 14 years old at the time, so she was older. She had some bruising that she wasn't out playing sports. She had pain in her knee and she was extremely tired. She, could hardly hold her head up. They brought her in. and her initial white blood cell count was 0.1. Normal is 7 to 10, around there, 0.1. And her hemoglobin and hematocrit were also low. And she was admitted, diagnosis leukemia. So then what do? So now we've got the blood counts. We've done the smear. We've seen immature leukocytes, which is ALL, right? Low counts follows suit. And they're going to do a lumbar puncture because we want to make sure it's not in the central nervous system. And of course, we will look at the bone producing area, the bone marrow, to see what is going on. And when we look at the blood again, we're going to see those really immature leukocytes. So once we have done all of the treatment, looking at all the areas in the body, now we're going to start chemotherapy. These children will get a port in, so they're not stuck all the time with a needle for every chemotherapy agent. And the children do really good with it. And parents know they're coming in to the ER because they're a fever or something. They put their little Emla cream on it with a Band-Aid over it. So it's nice and numb for us, so we can stick a little needle in it and get our blood and start our IV. So in chemotherapy, what do we do first? It is the induction therapy. Induction means it's that beginning, it's 4 to 6 weeks, and our goal is remission, okay? Once we have remission, they will put them on just prophylactic for that maintenance period of time. So our goal is to get rid of those cells that don't work, and then get into that remission. Now, sometimes the body's not working the way we really want it. We've done the chemotherapy, we've eradicated all the cells in the body, and they decide they need to do a stem cell transplant. Now, you know, if we have the patient's own stem cells, it's called autologous, auto. That's mine, auto. If it is somebody else's, it's allogenic stem cells. And these can be used, and it doesn't have to be a relative, doesn't have to be a blood type. We can use many different donors for this. We do have those umbilical cord bloods now. There's that umbilical cord bank that many parents decide to use, but do you know if their kid's going to have leukemia or something you need it for, and is it worth the cost? I mean, that's what many parents go through, because it can be quite expensive keeping those cells on ice for how long you need it. Now, this is a transplant, so there's always rejection. Can you imagine having something in your blood that's now rejecting? It could show anywhere. I saw a girl whose face was on fire with a rash from a stem cell transplant for sickle cell, and it was stem cell transplantation. So it could be anywhere. And again, it can cause severe organ damage. So autologous is your own cells, and allogenic is from somebody else. So again, here we are. You've got the young child, ages 2 to 5, remember? Most common ages. You're going to prepare that child. Let them know what's going on. Again, get on their level first, talk to them. Don't just go in there and start giving them things. Give them a moment. We are going to help with pain. It does hurt. Like I told you, that my next door neighbor, she had pain, a lot of pain in her leg and her knee, which is what caused her to go in. So make sure that we take care of that. We do want to prevent any complications from the suppression, infection, hemorrhage, and anemia. We will be giving blood as needed, giving antibiotics as needed. This is another diagnosis where temperature over 100.5, they need to call their physician or go to the emergency room. And as nurses, we need to be careful with the chemotherapeutic agents. You know, working in oncology in pediatrics is one of those specialties they pay big money for. These little bonuses, $10,000, $15,000, $20,000 if you'll work for them. So it could be a very lucrative area to work. So prognosis of leukemia, well, depends. What was that white count when you first came in? Was it 0.01? So that's 10,000, 10 versus 100, 0.1. So depends on where it was. How old were you? And if it's the ALL or the AML, like I said, gender, male or females. Females do better than males. And then what is the type of blood? Or do you have a weird type of blood that it's hard to get those blood products that you need when you need them? That makes a big determination in a lot of blood problems. So children with cancer, when we think of cancer, we think of what do we need to do to take care of them? And it does depend on the type of cancer we have. Most of these cancer treatments involve chemotherapy, radiation therapy, and surgery, or a combination of all of them. Multiple drugs used depending on, the body's responses to them. And again, thank goodness they do have some sort of port that will be taking care of them. And these treatments, again, all should be through some really good experienced nurses. So when we are looking to take care of them, that early detection, is good. My next door neighbor did really well. She went on to go to University of Miami, and she has a PhD in psychology. So she did well. She really came out through the other way. Did she go into psychology because of what she went through? Who knows? Maybe it was part of it. So it was a good outcome for her. As I said, you're going to see pain, fever, bruising, petechiae, and just bleeding somewhere. One of the big things usually is that lethargy, just feeling horrible. Anemia, lymph nodes, large. We know that usually lymph nodes, you shouldn't be able to feel them, right? And then sometimes it's visual changes that's going on. So managing the side effects of treatment, we think of chemo, we think of nausea and vomiting. Remember, if we are giving chemo, today's protocol is we give antiemetics 30 minutes before chemo. Years ago, we used to just treat the symptom when they were vomiting. And that's like too late. So now we're doing the best practice, which is giving it before. When we're looking at cancer, we know it does, and chemo does tend to eat up the white blood cells, the immune system. So neutrophils are considered your, cells that help fight infection. If we see them less than 500, this child's high risk to catch an infection, especially one who's already immunocompromised, whether they be, with cancer or leukemia, doesn't matter. Neutrophil count less than 500 is very scary. And we do need to give now antibiotics immediately and put them on isolation so that we're not bringing more infection to them. So it's a broad spectrum antibiotic therapy. And then of course, prevention of infection, washing hands, washing hands, washing hands. And of course, if you're sick, wear a mask. Hemorrhage is a big deal. As I said, we have a lot of loss of blood. So we can give blood, we can give platelet counts, monitoring them during this whole thing. Bleeding precautions is big when you're talking about cancers that are in active therapy. If the child's at home, they can't be riding their bike, skateboarding, they can't go play football, softball, anything because of the chances of contact to their spleen and their abdomen and bleeding inside. And we know that anemia can happen during that induction therapy. Remember, this is that 4 to 6 weeks, that remission is our goal. And it's like so much chemo is put into the body that it does take some of the red blood cells and the white blood cells and platelets. So anemia during that time is very common. So to be monitoring it closely and giving blood transfusions as needed. If they're anemic, remember they don't have oxygen. Remember they're going to have low tolerance to activity. So this child should have limits on how much they can be up and out and playing. So I said nausea and vomiting, we're going to be giving it 30 minutes before, and we're going to be giving it for a good 24 hours, every 4 to 6 hours, as whatever the medication is. Their mouth tends to get swollen and feel horrible. We need to make sure they get nutrition. Nutrition helps a child. It's still growing. And I said, a lot of these children are young. They're 2 to 5 years old. They're still growing a lot. They do need nutrition to grow. So monitoring intake, monitoring nutrition, height, weight, and then looking at the proteins in the blood, okay? The prealbumin, transferrin, albumin are all related to protein in the blood, okay? So what sort of diet does this child get? High protein, high calorie, because we want them to get all the calories we can, and we want to give them all the fat we can. So high, everything. We want to give them much calories, much proteins, and full of fat. As I said, the mouth gets full of these mucal ulcerations. Be careful with the foods, not spicy area or really hot foods, because it can cause a lot more pain. And when we talk mucosal, it goes from mouth to anus. Anywhere in there can be irritated. So these children don't want to eat. They really feel, they don't want to eat because it hurts. So making sure that that food is what they like, that's bland, soft toothbrushes, because they will bleed. And then if there's something in the rectal area, they can sit in a nice little suds bath, and that can help. With problems with the head, neurological problems, these children, because they're not eating well, they're not drinking well, they can become constipated. These children will push down and bear down to have a stool, and this can cause stroking in the head. So we do not want that to happen. So stool softeners should be used. If a child is not up and out and walking, these children can, as I said last week, they get foot drop just like adults. So we need to keep that moving. And there is sort of neuropathies, peripheral neuropathies, of the nerves of the legs and the feet. And you might see them difficulty walking and falling because of numbness and weakness in their lower extremities. Another thing is jaw pain. Again, give them something for pain. If your jaw hurts and you can't chew, you're not going to eat. I know I have RA, and sometimes my jaw hurts and I can't close my mouth. I don't want to eat either. So I know these poor children don't either. Another thing that can happen is hemorrhagic cystitis. Again, just increase fluids and fluids. And these children, a lot of times, are so weak and tired, they don't want to get up and walk to the bathroom. If they're in the hospital, give them a commode, let them rest. Let them take care of their energy. It's better than them holding it and causing, this hemorrhagic cystitis. They lose hair, clumps of hair, in the next morning after all night, you can see them, just clumps of hair all over their pillowcases. Many families tend to just cut their hair off with them, especially dads. I've seen that happen. I used to bring in for the girls, little bows, little ribbons. And I'd say, okay, what color are we today? Or do we want a multicolor? And I'd put it in their hair and just make them feel special. And I'd put one in my hair too. And things like that, you think they're very simple. I'm telling you, it's huge, huge for these children. And it's huge for those parents too. These children are on steroids. And, when you talk Cushing syndrome, it's not fun. You get big and blown up, and you could see some examples here how much steroids can affect you, how it can cause a lot of teasing on these poor children. We should be avoiding those salt and to help a little bit with it. And then, of course, if they're older and really aware of their body image, to wear like looser clothes so you don't really see how big they are underneath. Getting ready for procedures. Most procedures that we do for cancer are all under sedation, whether it's just some midazolam, which is Versed, maybe a little propofol, something, bone marrows, all of these things, we do give them some sedation, or we knock them out to help them, because we don't want them to remember the pain. And it's not going to be just one bone marrow. They're going to have some, several times. So we don't want to do it. Explaining things as well as we can. And then, tell them, we will try for you not to have pain as much as we can. You might feel a little. Be honest, so they know what to be prepared for. We use those topical anesthetics. We do anesthetics during the procedure, deeper, just to try to keep it as painless as possible. Pain management, opioids and non-opioids. It doesn't just need to be, morphine. Remember, we have Toradol and we have ibuprofen, which in between can work really, really well. And always titrate doses. We can titrate up. Children are honest. They will tell you when they hurt. They're not like adults. Adults will say, oh, I'm in 10 all the time. Children, they'll give you the right face, or you can tell by looking at them. Now, there's two sorts of lymphomas, Hodgkin's and non-Hodgkin's. Hodgkin's lymphoma is usually, it's the lymph nodes with metastasis in the spleen, bone marrow, lungs, and other tissues. Now, the one thing about Hodgkin's disease, it is painless. These nodes that are coming out of the neck like that, they're painless. So when you see painless cervical supraclavicular here, lymph node swelling, we can say, ooh, very, very familiar to Hodgkin's. You can see cough, your stomach can hurt and don't feel like eating, fever, weight loss, don't want to eat, and then night sweats. So what do we do to evaluate Hodgkin's disease? Well, first of all, we want to see what symptoms do they have. So history and physical, we'll do a CBC, CRP, SED rate, some liver functions, and maybe just soft tissue x-rays. But what tells us for sure Hodgkin's disease is we will do a biopsy of that lymph node, again, under sedation, and we will find Sternberg-Reed cells. If we see these cells, we know it's Hodgkin's disease. And how do we treat it? Well, we treat it with radiation and chemo, one or the other, or both. And the long-term survival is really, really good. When we're doing radiation, one of the things that we need to tell these children and parents, never clean off those purple or blue or whatever color markings that they have, because those markings tell the machine exactly where that it needs to be zapped. It was done there last time, we need to do it there again. And again, prepare the child, prepare the family, let them know about side effects. And with all the chemo and radiation, there is a high risk of these children becoming infertile and not being able to have children. Non-Hodgkin's lymphoma is just more diffuse. It's usually happens with all over. You don't see the swelling as much, and it moves very quickly. So what do you see? Well, usually you're going to see that tiredness that's going on, like a leukemia. They're going to do a biopsy of bone marrow, and they're going to find it in there. And what we'll do is aggressive radiation and chemo, again, induction with our goals of remission up to the point, and we're even going to put it in the central nervous system to prevent that too. So our care management of this child, non-Hodgkin's lymphoma, is just managing chemotherapy and all those nasty side effects that we feel. Brain tumors, most common solid tumor in children. Some are benign and some of them are malignant, depends on the sort of cell. Now, how do we treat it? Well, our treatment is we want to get rid of that tumor. It's occupying space, it's squishing on the brain, it's causing some sort of side effect. It could be memory, it could be balance, it could be many things. So we want to get rid of it. A lot of times they'll do radiation, again, to shrink it, chemo to shrink it, and sometimes one or the other, and then they do surgery and remove it. And they try to get the whole edges, get it out of the brain. So brain tumors, what are we going to be looking for? Well, once we have a brain tumor, we know brain tumors can be headache and vomiting. And the thing with brain tumors, it might be a little headache and a little vomiting that progresses. So those symptoms get worse and worse as the tumor gets bigger, or you might even see them stumbling and falling over, or not able to express themselves, many different things, depending on where that tumor is in the brain. So once they've had surgery, there are complications, and there's things that as nurses we need to do. Well, we need to be assessing the neurological status. We need to be looking at the eyes, looking at the strength and movement of the extremities, monitoring their fluid, their I&O. Extra fluid in the brain can cause swelling too, so I&O is important. Many times you cannot position them on the surgical site, only off, and sometimes only on the surgical site. So really know what the physician says. Sometimes they only want the head of the bed up 45 degrees, so you can't put them up. So know that you can only have them at 45 degrees. Many of them have brain drains in, as we call them. Could be, just a Jackson Pratt, or it could be even monitoring, depending on the severity of this tumor that was in there. And keep them comfortable. If they, can't be moving around, give them enough sedation and pain medicine so that they are comfortable, and keep that family supported. Many times the whole head is shaved off and there's a big dressing on the whole thing, and prepare that child that they're going to take the hair. And, some girls say, well, at least can you save some, especially if they're older. And we want this child to have everything that functioning that they had preoperatively. Sometimes they don't, depending on where that tumor was. Now, a neuroblastoma is, yes, a brain tumor, but it starts with a tumor in the abdomen. Now, this infant in the bottom, it's very obvious that there's a tumor in that abdomen, but it'll go up into the to the brain. Now, these ones in the abdomen will grow large, and that's why I put that picture there. They are firm, non-tender, irregular mass. Non-tender, again. When we start to note it is usually when they start showing those neurological signs. We'll start to see, headaches. And I mean, an infant would be crying a lot. Something is going there. Vomiting could start, so pressure in the brain's going on. It could go to the point where your eyes swell because the brain is the tumor is pushing out, so the eyeballs come out in exophthalmos, and then you might see some bruising around the eyes. The problem with this thing is by the time we know about it, it's already been metastasized, okay? So prepare the family for all of these procedures. Let them know it's chemoradiation. And this is not a very common, thank goodness, it's only 6% of all malignancies. So this is one that's not much, but it does start with a lump in the abdomen or chest, and it goes to the head, and that's where it metastasizes. So bone tumors, osteosarcomas, this is a tumor on a bone, and it is cancerous. Usually you will see it's usually adolescents, a lot of boys with this. They'll start limping, complaining of pain in their knee or their hip that doesn't get better. It'll start to swell. Then you're going to start to see them get anemic. They're going to start losing energy. They're going to lose weight. They're starting getting infections. And it gets to the point where that pain is so bad, they go into the doctor, who orders a simple x-ray, and it just shows fuzz on the outside of it. And then, of course, a more intense CT MRI, and they do a biopsy. Now, once they do the chemotherapy and they found it, they know it's there, they need to remove it. There's not just take a piece of bone, the whole bone needs to come out. Now, it is usually the femur bone, so it's the upper leg. So what they do today is, our goal is to keep that limb. So we're going to save the bottom portion and put it up top, so that we have something for a prosthesis to hook into. And that seems to do better than just removing the whole leg, because that would be what happened. So it's called we salvage the limb, okay? And this really helps for the post-operative treatment and therapy, teaching the child to walk on a prosthetic limb. Wilms tumor. Wilms tumor is a cancer on a infant, usually boys, ages 3 to 5, African American. It is a tumor in one or other side kidney in the abdomen. And again, it's non-tender. Usually you're doing an assessment, doing sounds of the abdomen, and you feel this lump there. I had a 3-year-old boy come over after the Haiti earthquake, came in through some religious groups into my emergency room, and I was triage nurse. And everything was in French, all of the papers. I don't speak French that well. So I said, all right, let me just do an assessment and try to figure this out. Now, the abdomen wasn't that big yet. So I did my assessment. I did my vital signs. I did neuro checks. I listened to the lungs. I got to the abdomen, and the left lower quadrant had a softball, hard lump. And I went, this is a Wilms tumor. I'd never seen it before. I didn't even remember I knew what that name was anymore. And poof, it popped into my head. So one of the things about this tumor is it's fragile. And if you touch it, it can flick off and it can metastasize within the peritoneal cavity. So big thing of nursing, do not touch the abdomen. If you're changing a diaper, do it carefully so that you're not stimulating that abdomen. If you're cleaning, the peritoneal area, do it really carefully. So history and physical, we would see this abdomen, and now we're going to do an ultrasound, maybe just a CT and MRI, depending. And of course, we're going to look at CBCs to see what's going on. And it's a kidney tumor. So we're going to be looking at the urinalysis. What we do is chemo and surgery. Sometimes radiation, but more chemo and surgery. And again, it's a cancer, we'll remove it. And again, these children do really well. This is a picture of what the surgery might be on that child's belly. It's quite extensive. They're going to be taking this tumor out of there. Now, post-operatively, the biggest thing is that we have opened up the bowel. We want to make sure that the intestines are working, and that, of course, monitoring for infections. Once it's removed, they do really well, but it is big and it is scary. Rhabdomyosarcoma is the most common soft tissue, and you might see it in the eyes and the ears, or even the mouth, and you will see things like an earache, a runny nose, and you go in and you see these tumors in there. Retinoblastoma, this is that little white flash that you see with flash bulbs years ago. You see those white little dots? Well, we call this a cat's eye. Now, if you're outside and there's an animal in the backyard and it's dark and you shine a light, you'll see those white eyes, right? It's called a cat's eye. Well, this is what you'll see in these children. And that is literally what's going to tell you that there is a tumor in there. It is from the retina. They have to remove the whole eye, and eventually they need to put an artificial one in there. So irradiation, again, there's that little purple mark. Don't ever wipe it off, do chemo, and then we're going to be taking that eyeball out. This is a little boy who's just, they're putting in an eye, so nobody really never knows. Again, you know, you're having a family whose child, the last one I saw, the baby was 8 months old that we found. So they are young. They can be very, very young. Support the family and let them know what's going to happen as best as you know. Germ cell tumors, when you think of germ cell, I think of testicular sort of tumors. This is why boys should be checking, you know, like that monthly breast test. They should be literally doing a testicular check, seeing if there's any tumors. I have a story of an 18-year-old. 18-year-old came in complaining of testicular pain. So I was with another nurse in the triage area. She said, okay, pull your pants down. And she went to feel, and one testicle was the size of a softball. We went in, did a quick x-ray, ultrasound, and he already had metastasis all over. And in 3 months, he died. So testicular cancer is a big deal, and we can remove it if it's done quick enough. Liver tumors, you know, the best thing about livers is they grow back. So you can literally take out a piece and it will grow back. And you don't have to remove the whole liver. There's lobes of the liver. So surgical resection, treatment, of course, and then, of course, we'll do some chemo. So what is their survival rate of children with cancer? I mean, cancer is a hard thing in adults, but put it on a kid, it's hard on the family. It's hard on us nurses. We don't want to see any child die. But we're up to about 80% survival rate. So this is a great thing. And the one thing about cancer is that they're doing more and more treatments. They're doing more studies about it. And we know that the treatments that I knew even 5 years ago are changing today. So our goal is cancer-free. Any questions? That last part was pretty rough. Are you ready for your cahoots? Who wants to win? Tara, are you going to win? No. Megan? You going to win? How about you, Kelly? How about you, Dina? Going to win? All right. I believe there's 44 today. All right, let's get going. Hematology, cancer, immunology. Which statement best describes a neuroblastoma? Remember, this is the tumor that starts in the abdomen and it metastasizes to the brain. And remember, it's 5–6% of all tumors. It's not that many, thank goodness. And usually your diagnosis is done after it's already in the brain, because usually it's the symptoms of the brain that of the vomiting and headaches that brings them to the doctor. And Amber and Sean knew that. What is sickle cell disease? So it's genetic or disorder that affects the production of hemoglobin. The production is sickled. It doesn't restrict oxygen. It just doesn't have cells that it can go into. So it's the production, because the production, they're just making them the wrong shape. What is priority treatment for a newborn of an HIV positive mother? So you have a baby. Mom's HIV, what are you going to do for that newborn? Our goal for that newborn is to improve their immune system so that they don't get HIV. As I said, it's not a death sentence just because mom has it. They can seroconvert and live a normal life if you boost their immune system immediately. What are symptoms of sickle cell anemia? So the delayed growth was the part of it that added in there. Hand, feet, swelling, pain, vision, delayed growth, because no oxygen, you're not going to grow. Sickle cell anemia affects which cells? So it is your red blood cells, making sure that you knew that one. Good. What kind of hematocrit would somebody with sickle cell have, and why? Well, sickle cell disease, you know what happens? We have these sickle-shaped cells that are being formed. And the problem with them, don't they like die really quick? They're gone. They don't work. They're gone. So they're lower because those cells die faster. It's not that the production is decreased, is they're still being produced, but they dying quicker. What is the treatment for sickle cell anemia? What did I tell you is the first thing you need to do for sickle cell? Remember, sickle cell is when the cells get clogged up in the vessels. The blood vessels get clogged up. So number one, IV fluids. You want to dilate that vein, put heat, give something for pain, then antibiotics and electrolytes and bone marrow if you can. Aplastic anemia includes a depression of which blood cells? Remember A, I tell you A is without, like atresia, A without. That's how I remember this. Red blood cells, white blood cells, platelets, everything, A, they're without blood, basically. Everything needs to be replaced. most common type of anemia is? So iron deficient anemia is the most common of all of them. What causes pernicious anemia? It's actually the intrinsic factor is pernicious anemia. What is the intrinsic factor? And that is B12. Good job. Which symptom is the single most common symptom of anemia? So fatigue, and this is the most common. Complaining they're tired, they can't move, they're not being the same. It's usually what brings them into the doctor. When teaching parents about beta thalassemia, the nurse informs that the child is at risk for what? Well, thalassemia, those rectangle shells. Remember, they're dying and they're spewing the contents within the blood system. Remember, Cooley's anemia is the one that they only live on blood transfusions. So it is, there's no oxygen because the cells are bursting quick. There's no red blood cells to carry oxygen. And the insides of those cells are spewing iron within the cells. So they need iron chelation therapy. Nurse is caring for a child who has just died and the parents asked to be left alone to rock their child. What do you do? You're absolutely going to let them. I mean, this is their child. You need to give them time, you know, give them the support they need. Maybe they need some sort of religious person to come in, social worker, patient rep, whatever they need, give them. You know, it can't go on for, you know, a day, but, you know, giving them time to say their goodbyes. Absolutely. What is hemophilia? So hemophilia is your bleeding. So your PTT is prolonged, but your PT platelets are absolutely normal and you're missing some sort of factor in there. 8, 9 von Willebrand's, one of those. What is thrombocytopenia purpura? Remember what I said about P, thrombocytopenia purpura, ITP. So this is P platelets, very good. And you'll see that, you know, purple rash, petechiae in there, and you'll see bleeding, ecchymotic areas. And this is when you go ahead and we'll be taking that CBC and we'll show that the platelets are down. Thrombocytopenia can cause the following symptoms. So petechial hemorrhage is that rash, the bruising, and then usually it's a nosebleed that they come in with. That's how they get diagnosed. A chronic, it's happening more than it should. A multi-select. Child with hemophilia has fallen, knee is swollen, painful. Treatment would include what? So we're going to elevate it and we're going to put cold on it and we're going to probably wrap it up and we're going to rest. Absolutely no exercising this knee. Hot packs is just going to dilate it and let it bleed more. No, cold packs. What is the priority nursing action for a suspected blood transfusion reaction? What do you do first? First, we're going to stop that transfusion. Absolutely. It's just like if you see an IV that is infiltrated, first thing, stop the infusion. You see an antibiotic reaction, first thing, stop the infusion. Good. A child is admitted with neutropenia. Which nursing action takes priority? Which means you're going to have a neutrophil count less than 500. Neutropenia. What are we worried about with that? And it's hand washing. And it's not, contact isolation. No, they don't have anything that we're worried about. We're worried about giving them infection. And we do that by strict hand washing. As simple as that. Which symptoms would a healthcare professional expect to see in a child with leukemia? Think about my next door neighbor. What did she complain of? Why did she go to the emergency room and then found out it was leukemia? So bruising, being tired, and that bone pain. Hers was knee pain, right in the bone, it hurt. And that's the signs and symptoms that you would see with a child with leukemia. Your child with ALL has recent lab results with a platelet count of 10,000. What is your nursing action? What does a platelet count of 10,000 mean? They have acute lymphocytic leukemia. Their lab is low. What do you worry about? And it's bleeding. Remember, platelet, low counts of platelet, you worry about bleeding. And those things are not doing injections on this child, making sure you're following the results of it and protecting them from injury. A child with Wilms tumor, which action by a nursing student causes the faculty member to intervene. Wilms tumor is that big tumor on the kidney in the abdomen. And we do not want you to touch that abdomen and that tumor because it is very fragile and it could burst little pieces into the peritoneal cavity and spread the cancer just from touching it. Cancer of the body's blood-forming tissues, including the bone marrow, is called what? And it is called leukemia. Blood forming tissues, blood cancer, leukemia. All of the following are true concerning a neuroblastoma except. It's not common. Thank goodness it's not common. It is a lump that gets bigger, it crosses the midline, It's in the adrenal glands. And then when it gets to the point where it's a brain tumor, it could cause it swelling or the bulging of the eyes. And Kristen's back on top. Most common clinical manifestation of a retinoblastoma. And that's that cat's eye reflex, that white eye that you see. Very good. True or false? Immunizations causes autism. Absolutely not. Good job. That's where it all came into fact, where they're talking autistic children because your chickenpox vaccine was given right before it. So it had to have been that chickenpox vaccine. A child's complaining about skin markings for radiation therapy. They should be told what? So those markings are the guidelines. They must stay there because they tell them where to do the radiation. So you cannot wash them off. A multi-select. Nursing care of a patient with immune thrombocytopenia purpura, ITP. Remember, ITP, P is platelets, so it is a bleeding problem, okay? Low platelets, you worry about bleeding. So no IM injections. You're going to monitor the CBC for the platelet count. Corticosteroids are PRN, but it's not like sickle cell. You don't need to make the vessels bigger. You don't need IV fluids. Child can drink. It has nothing to do with that. So no fluids. Forget that one with ITP. That's only for sickle cell. You're going to do bleeding issues. No IM injections, CBC, and the corticosteroids is one of the treatments. That and your anti-Ds. When distraction is used, it helps what? I like to do video games. I like to bring in stickers. I like to do something. And when a kid is in pain or really scared, it stops them from thinking about it. It can really help you give them their care a lot easier. What assessment question needs to be asked with a child with possible rheumatic fever? Some questions from last week. Any sore throat or unexplained fever in the last 2 months? Because usually rheumatic fever is caused from a strep infection that wasn't treated or not completely treated. So sore throat's the big deal with rheumatic fever. Signs and symptoms of asthma. And coughing, shortness of breath, tight chestness, wheezing, prolonged expiratory phase. Yes, good job. A multi-select. Absolute contraindication for nasotracheal suction include which of the following? When shouldn't you go and look at a mouth? Epiglottitis and croup. Remember, there's swelling in there already. Epiglottis is swollen, and then croup is also swelling of the laryngeal So we don't want to cause any more swelling and cause any more decreased room for the child to breathe. Iron dextran is given via which route? You have a child with iron deficient anemia and they say, no, we're going to give iron dextran. How are you going to give it? And it's IM and it's Z-track. The reason is it burns and it's discolored and it can discolor the skin. So Z-track, put it in and we do the infants, vastus lateralis, and then as they get older, depending the age of the child. What cancer may present with painless, firm, and enlarged cervical nodes? And that's your Hodgkin's lymphoma. Yes, very good. Non-Hodgkin's is diffuse. You don't see it like the Hodgkin's. Thalassemia major is treated primarily with what? Cooley's anemia. The Mediterranean descendants. And it's blood transfusions, okay? Thalassemia is when the cells are that rectangle shape. They are immature and burst quickly, and the contents of the iron goes into the blood system and the iron levels go high. So they need to do chelation therapy. So no iron in their diet either. A yeast infection is an opportunistic infection of HIV, yes or no? And yes, it is, absolutely, for sure. It's one of the things. Pneumocystic pneumonia is the respiratory infection. Yeast infection can be in the mouth and it could cause problems, you know, and it can get big clunks in there, chunks of yeast. So they need to give medicine for that. They can also, you know, vaginally in the woman quite a bit there too. A multi-select. Treatment of osteosarcoma includes what? So osteosarcoma is the femoral bone, usually in males, adolescents, and we are going to be doing chemotherapy, radiation therapy, and our goal is to salvage the limb, but many times they have to amputate. It's not a stem cell transplant in this case. They have to take the cancer out. Once they take the bone out, the cancer is gone. Who are the best donors for bone marrow transplantation? So if it's not you, autologous, many people isn't there, they don't have a bone marrow that doesn't have, you know, a cancer in it. It's the siblings, your brothers, your sisters are a really good choice for that. They work the best. What is the most common opportunistic infection for children with HIV? Let's put an opportunistic respiratory infection for children with HIV. It's one of them. You know, it's PCP pneumonia. This is where they're breathing difficulty. And I remember working in the ER in the 80s where they said, oh, this person has PCP pneumonia, and I still didn't understand HIV. It was still new, and all I knew is that this younger female stopped breathing, and I said, oh no, she's PCP pneumonia, and I had to look it up. I'm like, what does that mean? That's how long ago it was. What would you consider to be neutropenia or low neutrophil count in children? I mean, we discussed what we should do for neutropenia. How do we take care of these children? But what's the number that's low? And it's less than 500. That's really low. I mean, 500 to 1,000 is low, but if you're looking at the lowest, less than 500. A primary characteristic of a brain tumor is what? So, as I said, with a brain tumor, you'll see vomiting, you're going to see headaches, but they're going to be getting worse and worse and worse. So the occasional becomes daily headaches or constant headaches. The vomiting has nothing to do with eating. It's your vomiting at all times. So, and the symptoms become worse and worse, or worser, or is that a word? And last question. A child is receiving the induction of chemotherapy. What does that mean? And that's an initial intensive chemo for 4 to 6 weeks with the goal of remission. Yes, very good. You were listening. Let's see how we did today. Number 3, Meg. Good job, Meg. Number 2, Kristen. Number 1, whoop, 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 whoop. Ash. Good job, guys. Number 4, Sean and Carly. That was a rough one. It's a shorter one for me. I want you all to please take do your attendance attestation, if you would. And any questions for me? You all have a good day. Thank you so much.
Thank you. Have a
Mr.
good day
Bogart?
and a week.
Yeah,
I do have a question.
sure.
For your exam review on Thursday, are you going to record it? Because I have to work, so I'm not going to be
Absolutely.
able to
All
be there.
exam reviews are recorded and you'll get the recordings for everybody.
Okay.
Yes, ma'am.
Awesome. Thank you.
You're welcome.